Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we will be discussing an introduction to increased destruction of erythrocytes. Several types of anemia, including those resulting from vitamin B12 or folate deficiency, chronic inflammation, renal disease, and iron deficiency, have a hemolytic component. However, these anemias are not primarily caused by hemolysis, and therefore, they are not classified as hemolytic disorders. Instead, they occur due to the bone marrow's inability to increase RBC production. These anemias are known as anemias with a secondary hemolytic component. In contrast, anemias that result primarily from hemolysis can be classified based on various features, such as acute or chronic, inherited or acquired, intrinsic or extrinsic, intravascular or extravascular, and fragmentation or macrophage-mediated. One of these classification schemes of anemia is acute versus chronic hemolysis, which distinguishes the clinical presentation. Acute hemolysis is characterized by a sudden, rapid onset that may be isolated, episodic, or paroxysmal, as seen in paroxysmal cold hemoglobinuria or paroxysmal nocturnal hemoglobinuria. Patients with paroxysmal cold hemoglobinuria experience hemolysis after exposure to cold, while patients with paroxysmal nocturnal hemoglobinuria may experience intermittent episodes of hemolysis. A hemolytic transfusion reaction is an example of a single acute incident. Although the cause may vary, acute hemolysis typically disappears or subsides between episodes, allowing the patient's condition to return to normal. Chronic hemolysis may not be apparent if the bone marrow is capable of compensating, but it may be interspersed with hemolytic crises over time that result in anemia. An example of such a condition is glucose 6-phosphate dehydrogenase deficiency, where the lifespan of red blood cells is persistently shortened, but compensation by the bone marrow prevents anemia. However, when the cells are exposed to oxidizing agents like antimalarial drugs, an acute hemolytic event occurs. Once the drug is withdrawn, compensation returns. In other chronic conditions, anemia may be so severe that the bone marrow cannot produce enough cells to compensate. Thalassemia is a condition that illustrates this point. While red blood cell production may be vigorous, each cell has an inadequate amount of a particular type of globin chain, resulting in decreased functional hemoglobin production. Consequently, the blood's oxygen-carrying capacity is consistently low. In thalassemia, cells undergo lysis due to excess normal globin chains precipitating inside the erythroid cells. This hemolysis exacerbates the reduced hemoglobin production, causing chronically low oxygen levels. Inherited hemolytic disorders, like thalassemia, are inherited from parents who carry mutant genes. On the other hand, acquired hemolytic disorders occur in individuals who were previously healthy but develop conditions or agents that destroy RBCs, such as infectious diseases like malaria. Hemolytic disorders can be classified based on whether they involve intrinsic or extrinsic defects in RBCs, with the latter caused by external agents. Intrinsic hemolytic disorders arise from abnormalities in the RBC membrane, enzymatic pathways, or the hemoglobin molecule itself. In the case of intrinsic defects, transfusing RBCs from affected patients into healthy individuals will result in a shortened lifespan for the transfused cells because the defect is in the RBC. However, transfusing normal RBCs into patients with intrinsic defects will result in normal lifespan for the transfused cells because they are normal. Extrinsic hemolysis refers to conditions that originate from outside the red blood cell, including substances in the plasma or conditions affecting the circulatory system. Although malaria protozoa and other infectious agents are located inside the RBC, they are classified as extrinsic because they invade the RBC from outside. Non-infectious extrinsic agents that can damage RBCs include antibodies against RBC antigens and prosthetic heart valves. Cross-transfusion studies have confirmed that in extrinsic hemolysis, the patient's RBCs have a normal lifespan in the bloodstream of a healthy individual, but normal cells are lysed more rapidly in the patient's circulation, indicating that something outside the RBCs is causing the hemolysis. Intrinsic defects, on the other hand, are typically inherited, while extrinsic ones are usually acquired. Intrinsic disorders are further classified as membrane defects, enzyme defects, and hemoglobinopathies, while extrinsic hemolysis may be immunohemolytic, traumatic, microangiopathic, or caused by infectious agents, chemical agents, or physical agents. Another way of classifying hemolysis is based on the site of lysis and related to the mechanism of lysis. Intravascular hemolysis occurs by fragmentation, which can take place within the bloodstream, as well as in the spleen and bone marrow. Macrophage-mediated hemolysis occurs when RBCs are engulfed by macrophages and lysed by their digestive enzymes. Extravascular hemolysis refers to lysis outside the vessels, either within the macrophage or in tissues where macrophages are present, such as the spleen and liver. Hemolysis. Hemolysis is detected by identifying the breakdown products of red blood cells, with bilirubin being a major product. Understanding normal bilirubin metabolism is important in explaining the connection between hemolysis and elevated bilirubin levels. First, normal bilirubin metabolism. Bilirubin production involves salvaging and recycling iron and amino acids of globin chains for new protein synthesis. The protoporphyrin component of heme is catabolized and excreted, aiding in the absorption of dietary fat. Normally, macrophages of the mononuclear phagocyte system, the spleen, bone marrow, liver, lymph nodes, and circulating monocytes, recognize and phagocytize aged erythrocytes, leading to a macrophage-mediated hemolytic process. Most of the degradation of RBCs takes place inside macrophages where enzymes disintegrate the phagocytized erythrocytes. Hemoglobin is hydrolyzed into heme and globin. The globin is further broken down into amino acids, which return to the amino acid pool. Iron is released from the heme and re-enters the plasma through ferroportin. It binds to its protein carrier molecule, transferrin, and is recycled to cells in need. Biliverdin, a linear molecule that appears green, is produced from protoporphyrin by heme oxygenase and is reduced to bilirubin, a nonpolar yellow molecule that is secreted into the plasma. This form of bilirubin is called unconjugated bilirubin. Unconjugated bilirubin is hydrophobic and must bind to albumin to be transported in plasma to the liver. In the liver sinusoid, the bilirubin dissociates from the albumin and enters the hepatocyte membrane via a process that is not yet clear. Once inside the hepatocyte, unconjugated bilirubin is conjugated with two molecules of glucuronic acid by glucuronil transferase to form bilirubin diglucuronide, a polar and water-soluble molecule. Conjugated bilirubin is transported into the hepatic bile duct and then into the intestines where it aids in the absorption of fats from the diet by emulsifying them. Gut bacteria oxidize the conjugated bilirubin to form urobilinogen, a collection of water-soluble compounds. Urobilinogen is mostly further oxidized to form stercobilin and similar compounds that lend brown color to stool. Some of the conjugated bilirubin and urobilinogen molecules are absorbed from the intestines into the plasma and collected by the portal circulation, which carries them directly to the liver. The liver recycles most of these bile products directly into the bile, but a small amount is excreted in urine after being filtered by the renal glomerulus. While conjugated bilirubin is virtually undetectable in urine, a measurable amount of urobilinogen is expected normally. The yellow color of urine is due to urobilin, a water-soluble derivative of urobilinogen. Second, we have normal plasma hemoglobin salvage during fragmentation hemolysis. Fragmentation hemolysis occurs when the membrane of red blood cells is damaged due to trauma, leading to the release of hemoglobin and other cell contents into plasma. This accounts for 10% to 20% of normal RBC destruction and is caused by turbulence and anatomic restrictions in the vasculature. The haptoglobin hemopexin methemoglobin system is a collective mechanism used to salvage hemoglobin iron and prevent oxidative reactions. Haptoglobin binds to hemoglobin and prevents it from being filtered at the glomerulus, saving iron from urinary loss. The haptoglobin-hemoglobin complex is taken up by macrophages, where iron is salvaged, globin is catabolized, and protoporphyrin is converted to unconjugated bilirubin. The haptoglobin-hemoglobin complex is then taken up by macrophages, which internalize it and initiate the process of salvaging iron and catabolizing globin. Macrophages express CD163, a scavenger receptor for the haptoglobin-hemoglobin complex, which facilitates its uptake and degradation. Inside the macrophage, iron is removed from hemoglobin and stored as ferritin or exported back to the plasma through the ferroportin transporter. Globin chains are catabolized into amino acids, while heme is converted to unconjugated bilirubin, which is further metabolized by the liver. Hemopexin is another plasma protein that binds to free plasma hemoglobin to prevent oxidant injury to cells and tissues. Hemopexin metheme complex binds to hepatocyte CD91 receptors and is internalized. The fate of the internalized heme is still being investigated, but some studies suggest that the intact heme can be integrated into vital proteins, like cytochromes, while others suggest that it is broken down to bilirubin, allowing for reuse of the iron. The level of haptoglobin in plasma is usually enough to salvage only the small amount of plasma hemoglobin generated each day. If hemolysis is accelerated, haptoglobin may be depleted as the liver's production does not increase in response to increased consumption. Excess methemoglobin and metheme will be filtered into the urine if the previous systems are overloaded. The kidney can reabsorb iron, and it is an area of active research yet to be fully elucidated. However, renal cells are able to transfer additional salvaged iron back into the plasma, and these systems evolved to manage the amount and form of iron present in normal urinary filtrate. Please don't forget to subscribe to our channel, activate notifications to get our new videos. If you like our content, please press the like button, and share the video with your friends. If you have any questions, leave a comment below. Excessive macrophage-mediated, extravascular, hemolysis. Hemolytic anemias can be caused by increased macrophage-mediated hemolysis, where more than the usual number of red blood cells are removed from circulation daily. Under normal circumstances, macrophages identify senescent RBCs and remove them from circulation, but pathologic processes can lead to increased removal of affected cells. When the number of affected cells exceeds the quantity removed due to senescence and the bone marrow cannot compensate, anemia develops. Excessive oxidation of hemoglobin can cause the formation of Heinz bodies, which can be detected by macrophages, leading to premature removal of RBCs from circulation. Macrophages ingesting RBCs results in lysing of RBCs within a phagolysosome and processing of its contents within the macrophage, causing extravascular hemolysis. Defective cells display markers like those of senescent RBCs, which are recognized by macrophages in the spleen and liver, leading to their removal. Spherocytes are formed when a macrophage ingests a portion of the membrane, leaving the remainder to reseal, resulting in the characteristic shape change associated with macrophage-mediated hemolysis. In macrophage-mediated hemolytic anemias, total plasma bilirubin levels rise due to premature RBC lysis, and the increase in unconjugated bilirubin leads to increased urobilinogen in the urine. Increased unconjugated bilirubin in the plasma is bound to albumin and cannot pass through the glomerulus, hence not appearing in urine. Hemolytic anemias are caused by increased macrophage-mediated hemolysis, where more than the usual number of RBCs are removed from circulation daily. Senescent RBCs display surface markers that identify them to macrophages as aged cells requiring removal, and pathologic processes also lead to the expression of the same markers, so cells are recognized and removed. Anemia develops when the number of affected cells increases beyond the quantity normally removed each day due to senescence, and if the bone marrow cannot compensate. Excessive oxidation of hemoglobin causes increased formation of Heinz bodies, which bind to the inner surface of the RBC membrane, producing changes to the exterior of the membrane that can be detected by macrophages, leading to premature removal from circulation. When an RBC is ingested by a macrophage, it is lysed within a phagolysosome, and the contents are processed entirely within the macrophage. Sometimes, the macrophage ingests a portion of the membrane, leaving the remainder to reseal, resulting in the characteristic shape change associated with macrophage-mediated hemolysis, spherocytes. Defective cells display markers like those of senescent RBCs, so macrophage-mediated hemolysis of defective cells occurs most often in the spleen and liver, where the macrophages possess receptors for those markers. In macrophage-mediated hemolytic anemias, the total plasma bilirubin level rises as RBCs lyse prematurely. The rise of the total bilirubin is due to the increase of the unconjugated fraction. As long as the liver is healthy, it processes the increased load of unconjugated bilirubin, producing more than the usual amount of conjugated bilirubin that enters the intestine. Increased urobilinogen forms in the intestines and is subsequently absorbed by the portal circulation and excreted by the kidney, leading to increased urobilinogen detectable in the urine. None of the unconjugated bilirubin appears in the urine because it is bound to albumin and cannot pass through the glomerulus. Excessive fragmentation, intravascular, hemolysis. Fragmentation hemolysis can be a major feature of pathological processes, although it is a minor component of normal red blood cell destruction. Examples of fragmentation hemolysis include the physical lysis of RBCs by prosthetic heart valves and the bursting of mature intracellular RBC parasites such as malaria protozoa out of the cell. Excessive fragmentation hemolysis leads to the appearance of red blood cell contents, mainly hemoglobin, in the plasma. This causes methemoglobinemia and leads to the formation of complexes between salvage proteins and their ligands such as hemoglobin haptoglobin, methemhemopexin, and methemalbumin. Free haptoglobin levels decrease due to the formation of more than the usual amounts of the complex, which is then taken up by macrophages. The endocytosed protein is not recycled to the plasma, and there is no compensatory increase in production, causing a depletion of haptoglobin in the plasma. Free hemopexin levels can also decrease, although not as dramatically as haptoglobin since some recycling continues. Hemoglobin can also appear in the urine, hemoglobinuria, if the amount of liberated hemoglobin and heme exceeds the salvage capacity of the plasma proteins. Renal cells are able to reabsorb more than usual amounts of iron, heme, or iron-containing proteins through the megalincubulin receptor endocytosis system, which is responsible for nonspecific but very efficient reabsorption of proteins from the urinary filtrate in the proximal tubule. Proximal tubular cells can dismantle heme from hemoglobin via heme oxygenase 1, contributing to elevations of unconjugated bilirubin in plasma and thus freeing the iron for export to the plasma by ferroportin. Proximal tubular cell iron in excess of what can be transported into the circulation is stored as ferritin, and some is converted to hemosiderin. If the tubular cell is sloughed into the filtrate and appears in the urine sediment, the hemosiderin can be detected using the Prussian blue stain. Elevated levels of plasma indirect bilirubin and urinary urobilinogen are also measurable, although not immediately. Following an acute onset, a rise in reticulocytes several days later would also be seen, which assists with the differential diagnosis. Clinical features. Hemolysis can cause anemia and general symptoms such as fatigue, dyspnea, and dizziness. Pallor and tachycardia can also be expected. Increase in plasma bilirubin can cause jaundice and icterus. This can occur in other conditions besides hemolysis, but if it's caused by hemolysis, it's called hemolytic jaundice or prehepatic jaundice. Unconjugated bilirubin can deposit in the brain, causing kernicterus in newborns. The frequency or constancy of jaundice can provide clues to the cause of hemolysis. Chronic hemolysis can cause splenomegaly, gallstones, bone deformities, and methemoglobinuria, which can lead to acute renal failure. Acute hemolysis can cause malaise, aches, vomiting, and possible fever. Fragmentation hemolysis can lead to profound prostration and shock, flank pain, oliguria, or anuria. Brown urine is associated with fragmentation hemolysis. As for the laboratory diagnosis, first we have tests of accelerated red blood cell destruction. Can be detected through various laboratory and visual examination methods. Fragmentation hemolysis can be suggested through visual examination of plasma and urine. Methemoglobin, methemoglobin, and hemopexinheme can give a coffee brown color to plasma, while urine can have a root beer or beer color. Normal physiological fragmentation hemolysis produces less than 1 mg per deciliter of plasma hemoglobin. Plasma does not become visibly red/brown until the plasma hemoglobin level is at 50 mg per deciliter. Typical values during hemolytic processes may be as low as 15 mg per deciliter. The urinalysis test strip for blood can be positive even when the hemoglobin is not present in a high enough concentration to change the color of the urine significantly. A complete blood count can help identify the cause of hemolysis. Spherocytes can be seen with macrophage-mediated hemolysis, while fragmented cells or schistocytes are noted with fragmentation hemolysis. An increased rate of hemoglobin catabolism results in increased amounts of plasma unconjugated bilirubin and carbon monoxide. A substantial decline in the serum haptoglobin level indicates fragmentation hemolysis. Low values suggest hemolysis but may be due to impaired synthesis of haptoglobin caused by liver disease. Tests to determine the rate of endogenous carbon monoxide production have been developed, but they are not typically required for clinical diagnosis. Other laboratory test results may be incidentally abnormal, such as increased serum lactate dehydrogenase activity. Then we have tests of increased erythropoiesis. Tests for elevated erythropoiesis can provide valuable information regarding the presence of a hemolytic process, especially if the bone marrow is healthy. The hypoxia associated with hemolysis triggers an increase in erythropoiesis, which can be detected by an increase in circulating reticulocytes and, in severe cases, nucleated red blood cells. These laboratory findings persist in chronic hemolytic disease and typically manifest within 3 to 6 days after an acute hemolytic episode. However, it's important to note that increased erythropoiesis is not exclusive to hemolytic anemias and cannot serve as a definitive diagnosis. Comparable results can also be observed in cases of hemorrhage and in patients receiving specific therapy for anemia caused by deficiencies in iron, folate, or vitamin B12. Nevertheless, evaluating erythropoiesis can aid in assessing the effectiveness of the bone marrow response and should be considered in the differential diagnosis. Also, we have complete blood count and morphologic features. Peripheral blood film evaluation is crucial in diagnosing hemolytic anemia. An increase in polychromatic RBCs, reticulocytes, and nucleated RBCs indicates bone marrow compensation for hemolysis or blood loss. Schistocytes are expected with excessive fragmentation hemolysis, while spherocytes may be seen with macrophage-mediated processes. Additional morphologic changes to red blood cells may point toward the cause of hemolysis. An increase in the mean cell volume, MCV, is usually seen with extreme compensatory reticulocytosis resulting from larger, prematurely released, shift, reticulocytes. Exceptions occur if the hemolytic condition itself involves smaller cells that counter the increased volume of the reticulocytes. Leukocytosis and thrombocytosis may accompany acute hemolytic anemia and are considered reactions to the hemolytic process. Conversely, conditions that directly cause leukocytosis, such as sepsis, might cause hemolysis. Low platelet counts in association with other signs of hemolysis may indicate a platelet-consuming microangiopathic process, such as disseminated intravascular coagulopathy. Reticulocytes count. The reticulocytes count is a commonly used test to identify increased erythropoiesis, which can occur during hemolysis or hemorrhage. If the bone marrow is healthy and there are enough raw materials, all measures of reticulocytes production should increase, including absolute and relative reticulocytes count, reticulocytes production index, and immature reticulocytes fraction. An elevated reticulocytes count in an anemic patient without hemorrhage should prompt an investigation into a possible cause of hemolysis. Generally, the severity of the hemolysis correlates with the degree of reticulocytes increase, but there are exceptions in cases of some hemolytic anemias with hypoplastic marrow or aplastic crises. Bone marrow examination. Hemolytic anemia can usually be diagnosed without performing a bone marrow examination. However, if it is conducted, it will show an increase in erythroid cells resulting in reticulocytosis in the peripheral blood. This increase in erythroid cells leads to a decrease in the overall myeloid-to-erythroid ratio. To accurately determine the cellularity of the bone marrow, a core biopsy specimen should be used rather than an aspirated specimen. Finally, we have the laboratory tests to determine specific hemolytic processes. Spherocytes or schistocytes on a peripheral blood film can suggest hemolytic anemia. Other abnormalities on the blood film, such as elliptocytes, acanthocytes, Burr cells, sickle cells, target cells, agglutination, erythrophagocytosis, or parasites, can help identify the specific disorder causing the hemolysis. Specific tests for different types of hemolytic anemia are direct antiglobulin test, osmotic fragility test, eosin 59 maleimide binding test. Heinz body test, RBC enzyme studies. Serologic tests, and immunophenotyping. Thank you for completing the video. Remember to ask for ASCP short notes, and don't forget to subscribe. Bye.